So my task here is to walk you through some of the challenges in making a diagnosis of coronary disease in female patients. And it's not going to be all doom and gloom. At the end of my talk, I'm going to talk about something that I think is actually extremely exciting and some work that I've done with this test. So by way of background, I think we've discussed many of the issues and why we're here tonight to discuss why we want to focus on the female patient population. Yes, it's more than 50% of the US population. We're looking at an aging patient population, life expectancy of 81 years of age. Postmenopausal women, we're talking about 33 million women in the United States. And again, this is the substrate of patients that are at risk. So let me try and help explain, and I think much of this has been discussed already, but let me try and explain why it's so challenging in the female patient population to come to a diagnosis of obstructive coronary disease. So again, I think the story starts here. What we're talking about here is angina, right? The patients come into the office, they may have some risk factors, but typically they're coming forward with symptoms. So I think the first thing to be aware of is, and I think Harry Hemingway did a beautiful job in this population-based analysis, is to establish the fact that in fact the prevalence of angina in female patients is higher than in male patients. And what he found in this study, where he's looking at over 400,000 patients in 31 countries, that the prevalence of angina is about 20% higher in female patients compared to male patients. And while I realize this is very, very small, these little dots here represent the US female patient population. And in fact, the highest prevalence of angina actually is in the United States among our female patients, 40% higher than anywhere else in the world. So if you think about it, we're talking about just a larger denominator, if you will. So I think, when you go back and you discuss the symptoms, I think we've been very much sensitized to the fact that typical symptoms can be typical in men and women, and we're very familiar with those. But what we've been sensitized to is that women can present with milder symptoms. And that may be leading, to a certain extent, to that higher prevalence of angina. And while I think it is good to identify more patients coming forward, I think we need to be aware of the impact of that higher prevalence of angina and what the implications might be. So Noel actually showed this slide and has shown that this is applicable across the board of acute coronary syndromes, but what this is telling us is that when you take patients to the cath lab, and this happens to be a patient population with stable chest pain, the prevalence of obstructive coronary disease in female patients is always lower than in the male patient population. So what am I saying here? What I'm saying is that the pretest likelihood of obstructive coronary disease is lower, systematically lower in female patients than male patients. And we know that that is going to impact the accuracy of our non-invasive tests. So let's talk a little bit about the classification of chest pain. And again, Diamond Forrester is no classification. I think it's very relevant. I think it's very useful, at least in clinical trial settings. And it's based on 3 criteria. First of all, the characteristics and the quality and duration of the chest pain syndrome, whether it's provoked by exercise or emotional stress, and then thirdly, whether it's relieved by rest or nitroglycerin. So the way the classification goes is if you have 3 criteria, that's classified as typical angina. If you have 2 criteria, atypical angina. And if you have 1 or 0 criteria, then it's classified as non-anginal chest pain. So why are we going through this? Well, this has been validated against the prevalence of obstructive coronary disease. So what you can see here is if the patient comes in as asymptomatic, the prevalence of obstructive coronary disease is actually very low. Obviously increases a little bit with age. If you take a look at the male patient population here in the blue, you can see that there's a very steep and linear relationship here that correlates the symptoms, right, with the prevalence of obstructive coronary disease. So if you have atypical angina, you have a much higher prevalence, above 60%. And obviously, if you've got typical angina, it's extremely high, above 80%. Now, let's take a look at the female patient population. While there is a strong correlation, right, with symptoms and the prevalence of angina, it's not as striking as what we're seeing in the male patient population. And in particular, if you take a look at the non-anginal patients, female patients here, you can see that up to above 20% of these patients, female patients with non-anginal symptoms, actually do have obstructive coronary disease. But the main point here is that that relationship is not as striking as what is seen in the male patient population. This is, I think, very important work that Rita Redberg and her group did several years ago. It was published back in 1999, but I think it's actually very relevant to this discussion. What this is a meta-analysis looking at women specifically, where we're looking at the positive predictive value and the false negative rate of 3 non-invasive diagnostic tests. So in yellow is the treadmill ECG, standard treadmill ECG. In blue is the nuclear stress test, or the MPIs. And in gray is the stress echoes. So the good news with these tests, specifically in the female patient population, is that it improves your positive predictive value by about 20%. So if you present with definite angina or probable angina and you have a positive test, it will improve your diagnostic accuracy by about 20%. That's the good news. The bad news is if you have a negative test, your false negative rate, particularly in the patients with definite angina, is extremely high. You can see here, if you have a negative treadmill test, up to 57% of these patients actually did have obstructive coronary disease. So what this is telling us is that these tests are actually not very good at ruling out disease, right? And even if you have probable angina or atypical symptoms, up to 20% of these patients with a negative test will, in fact, have obstructive coronary disease. So again, you'll come home, you'll go for your diagnostic test, you have symptoms, test comes back negative, you're not really sure that you're free and you don't have any issues. So now this is our guidance document. This is the American Heart Association consensus statement on the non-invasive testing in female patients. This was published back in 2005, and it's, again, specifically in the female patient population. So the way the guidelines tell us to screen our patients is that if they come in with intermediate or high likelihood or typical or atypical symptoms, the first line of testing should be a standard treadmill ECG. The very test that I just told you had a very high false negative rate. Only amongst diabetics or those with an abnormal baseline ECG should you go to imaging studies, okay? So those are our recommendations. Now, I think it's important, having said all the negative things about non-invasive tests, in our ability to diagnose obstructive coronary disease, I think certainly the prognosis of these tests, so having a negative test, whether you're looking at an exercise MPI or a stress echo, if you have a negative test, there is you have a very high negative predictive value, and the likelihood of having cardiovascular events down the road is extremely low. So obviously, in terms of prognosis, these tests are actually very, very good at excluding subsequent events. Having said that, I think the issue is that we're always wanting to understand whether our patients have obstructive coronary disease. And we're still stuck with the problem that many of these patients are actually being sent to cardiac catheterization to make a diagnosis or rule out the presence of obstructive coronary disease. And this is a very important study that was published back in 2010 in the New England Journal of Medicine, Looking at the ACC and CDR, you can see a very large number of patients, close to 400,000 patients, 663 hospitals throughout the United States, where you see that 62% of the patients undergoing a diagnostic angiography actually had no or minimal stenosis. So many of these tests, diagnostic tests, could potentially, if we had better ways of screening these patients, could be avoided. And I think that's the main point here. So again, the non-invasive pathways, I think, can certainly be improved. I think currently they lead to many unnecessary invasive tests, and there's a whole host of reasons. Variable site-dependent diagnostic accuracy may be an issue, very high false positive rates, referral bias, exercise intolerance, again, a whole host of reasons, but nonetheless, here we are with many patients being referred to diagnostic angiography, and if you look at the series out there, it ranges anywhere from 50 to 60% of caths. So let me shift and talk a little bit about the PREDICT trial, and I think what is very, very exciting in this test, and I think this is very novel. So I was very fortunate to be involved with the PREDICT trial. This is a prospective study that was designed to validate, again, a test, which, just to spend a little bit of time on this, is a sex-specific, takes into account the age of the patient, and is based on an algorithm that looks at the expression of genes. So the way the study went is that these were patients that were identified and actually referred for cardiac angiography. So they had symptoms, or they had risk factors, referred to cardiac angiography. About 70% of these patients actually underwent myocardial perfusion imaging. They were approached for enrollment. If they signed informed consent, they were enrolled in the clinical study, and a blood test was done and sent off for core CAD test. Then they went sent off to the cath lab, and then the angiograms were then analyzed offline using quantitative coronary angiography. And the way we identified or defined patients with obstructive coronary disease was on the basis of quantitative coronary angiography, defined as a threshold of 50%, which correlates with about a 70% visual stenosis. Again, if you think of all the tests, the non-invasive tests that are available to you, none of them are sex-specific. This is the only one that I'm aware of that actually takes into account the differences in prevalence between men and women, and we know that there clearly are differences, and I'll go over this data, and also takes into account the age of the patient. So these are two very important criteria that, again, this test will take into account. The expression of the genes are based on leukocytes. So these are inflammatory markers, again, of atherosclerosis. So again, very, very unique test that is looking at the biology at that point in time of the patient. So what we did was that we looked at a gender sub-analysis of this study. So we had 1,160 patients. Overall, there was 42% were female in the patient population. And you can see here the overall prevalence of obstructive coronary disease was 36%. So right on target in terms of what I showed you from the Patel publication. You can see that the prevalence of obstructive disease was slightly higher in the male patients. It was 47%, and clearly lower in the female patients. Again, less obstructive coronary disease in female patients. And then this very typical probability of CAD, looking at the men, where you have a linear relationship or a linear increase in the probability of obstructive coronary disease with increasing age. And in the female patient population, again, very characteristic, you see very flat until the perimenopausal time frame, and then an acceleration after the age of 60, and almost a catch-up to the male patients. This is looking at the frequency of near normal angiograms. And again, you see a much higher prevalence in the females. So about anywhere between 65 to 70% of these women had near normal angiograms. In the male patient population, it was lower, but still, nonetheless, it was 40 to 43%, depending on how this was being assessed. So we were interested in looking at some of the predictors. What predicted obstructive coronary disease? Are the risk factors different between men and women? And in fact, when we looked at the baseline demographics, the characteristics were actually very similar between the sexes. So you see age, hypertension, dyslipidemia, all very significant here in the females. Same characteristics in the male patient population in predicting obstructive disease. So these are the cases. To take this one step further, we were interested in looking at the clinical risk score, which takes into account the age of the patient, the gender, and then the chest pain characteristics based on Diamond-Forrester. And this is an ROC analysis. You're looking at an area under the curve in the male patients in blue of 0.66. So there is, again, value in the male patients. In the female patients, it was 0.5. Completely irrelevant, did not help us one bit. And this is interesting. So we understand this is a little bit of a biased patient population. These are patients that are going to the cath lab. But nonetheless, again, 70% of these patients had myocardial perfusion imaging. And I just want to highlight this because I think this is very sobering. So in the females, so the yellow group here, this is not working very well, but the yellow ones are the women, the blue, the men. What you're looking at here is that those patients with a positive MPI, only 22% of them actually had obstructive coronary disease. Of those with negative MPIs, for females, 18% did have obstructive coronary disease. So these were the false negatives. And actually, it was worse in this particular study in the male patient population. You can see the false negative rate in the males was actually 45%. So I think this, again, is very sobering data to look at. What we wanted to understand, again, coming back to the issue of symptoms in female patients, is do symptoms add to our positive predictive value over and beyond when we're doing the myocardial perfusion imaging? What you can see in the blue lines that for the male patients, it does. So if you've got typical symptoms, obviously, you've got a much higher positive predictive value, atypical, etc. In the female patients, you can see it's completely flat. So again, the symptoms are really not helping us in reaching a diagnosis here over and beyond what we're achieving with the myocardial perfusion imaging. And then finally, when we're doing a test, I think one of the key things is being able to rule out disease, right? We want to send our patient to a stress test or whatever, a CT angiogram, and we want, if we have a negative result, we want to be able to reassure our patient that she or he can go home and not worry that they have some issue that's going to lead to an event. So I think in the context of our female patient population and all the challenges that we have in making that diagnosis, this may be a non-invasive blood test that would help us actually exclude or rule out disease or obstructive coronary disease. So that's all I have. I think the standard non-invasive diagnostic tests, I think there's certainly enormous room for improvement. I think we're seeing a lot of inappropriate diagnostic catheterizations, all the complications that are associated not only with invasive angiography, but also with the non-invasive tests that Dr. Redberg was talking about.